Let's talk about the first thing that we do in a knee replacement. The first thing we do is we design the alignment of the knee. You've all seen bow-legged Cowboys and you've seen knock-kneed patients. One of the things that is integral in the knee replacement is to correct that. Well, historically, we put a rod up the femur and we cut it at, say, 5 degrees. And then we take a extramedullary or an outside of the leg guide and we cut the tibia at 0. And our goal is a line from your hip through your knee through your ankle. But that whole theory assumes that everybody's the same. Well, we all know people who are bow-legged. They probably should be kept a little bow-legged, because if we try to make that patient perfectly straight, you have to release the medial collateral ligament. And that's something that has been done for 50 years. And the trend now is to leave that ligament snug, intact, and snug and tight so that it stays stable throughout the recovery, because you need your medial collateral ligament. If you've ever injured your medial collateral ligament, you realize that that's a bad injury just in and of itself. So with robotics, rather than make those arbitrary cuts at, say, 5 degrees and 0, we actually go in with your implant and CT scan already designed, and now we design the gap. And the implant itself takes up about 18 millimeters. You want the gap on the inside of the knee and the outside compartment to be 18 millimeters. We're able to do that. We're able to adjust on the fly, so we're not making everybody the same anymore. We're balancing the knee to your ligaments. And that's one of the critical things that robotics allows us to do.